Welcome to the Sexy Aging Podcast. I've been looking forward to this episode, or definitely this interview with Dr. Linda Deer, the Meno Doc. I call her Doc. And we've met because, well, we're obviously in the same space talking about menopause. Linda is a specialist in this area. It's a deep passion of hers. You've got quite a few letters behind your name, Linda. So how about we start with that? Oh, no, hang on, one more thing. You're a Scouser in New Zealand. That's awesome. If you don't know what a Scouser is, then look it up, or Linda could actually tell us all about it. So got a few letters behind your name. Talk to us about that. Who are you and what do you do?
I have got a few letters. I think I'm just indecisive, maybe. So, yeah, I've studied a few things. I've studied psychology. I've been to med school. What do the other letters mean? I've done a diploma in women's health. I've done a menopause practitioner qualification. What else have I done? And yes, I'm from Liverpool, which is what a Scouser is. Although I don't sound as Liverpudlian as I used to, unless I get drunk, and then I do.
And then it all comes out.
It all comes flowing back.
Yeah. I think my husband would really love being with you, because one of his best friends is also from Liverpool when he flattered back in the day, and he just, the crazy things that they used to talk about, just the hilarity of the way that it sounded. So yeah, that would be cool. We'll notch that up for something to do in the future.
Get me drunk next time.
Yeah. And you've been a personal trainer, so that's something that we're both really passionate about, is women's fitness and health, really taking care of yourself. And you actually started, was that one of the very first things that you started when you were studying, or?
Yeah, so I did that just before medical school.
Yeah.
So I did my psychology degree, then worked in psychology, and then got really into fitness and did a training course to work as a personal fitness trainer and as a yoga teacher, and loved that, and did it while I was at med school, mainly to pay my way through med school as well.
Mm-hmm.
And I think it's something that helps me now, especially in perimenopause and menopause, because there's so much about lifestyle that matters. So yeah, it's a part of my life that I loved at the time and is still very useful to me now.
Yeah. Now, and something that we both, really, it's one of our values, isn't it? Is we move our bodies, we protect our minds, we look after the way we feel during this stage of life. But today we are talking about a quite in-depth topic, and I've got a lot of questions. So it's probably going to be a lengthy episode. I think we're just going to go for it, get it done. Throughout the last couple of weeks, I have spoken to some women who have had the experience of a surgical menopause. Needless, should I just say that I found the experience of interviewing quite hard. I'm just being honest, just to listen to the experience. I can't say that everybody has had negative experiences. I would just say I'm looking forward to talking to someone that has had a good experience. But really, I think what I want to do now is just, get the questions out there. People have asked questions in our Facebook community as well, so I'm going to bring those to our conversation today. We're talking about surgical menopause. It's a big topic. It's not that much known about it. I mean, I didn't know anything until I spoke to Emily. So, yeah, this is big, right?
It is big, and as you say, there's a blind spot though. I mean, there's a blind spot to menopause in general. I think it's not, doesn't get enough attention as a whole, and then within menopause, there's another big blind spot, which is surgical menopause.
Yeah. So, what exactly is it? Like medically, what is surgical menopause? I think that's the first place that we should start, right?
Yeah, because we want to know what we're actually talking about. So the strictest definition of surgical menopause is when a person has their ovaries, both of them, surgically removed. So that is the very strict definition. So that means that woman has been thrown into full-on menopause immediately, because both the ovaries are gone. So all the hormones they made, the estrogen, the progesterone, and the testosterone from those glands, is now gone out of her body. So that is an overnight menopause. Now, it does get a little murky or blurred because there are other operations that are done to a woman's body that are not fitting that definition specifically, but they can upset the ovaries to such an extent that you do then go on to get some menopausal symptoms earlier than you probably would have. And I'm talking about things, even just a hysterectomy has been shown. So a hysterectomy is when we just take the womb out and you can leave the ovaries behind. Sometimes they take the ovaries as well, but lots of women just have a hysterectomy. So it's just the womb and the ovaries are still there. So from a very basic point of view, you could say, well, they're not menopausal because their ovaries are still there making the hormones. But what we think sometimes happens is the blood supply is upset when you remove the womb because all that stuff's connected. And in some women, it can accelerate menopausal symptoms. And the other sort of grey area is if a woman has one ovary removed, which is often done as well for various reasons, and she's got one left behind, you know, that's kind of half a surgical menopause, really. And yet it doesn't fit into any of these categories very nicely. So some women feel like they're in this no man's land between surgical and natural. And they often feel quite in a blind spot as well. But strictly speaking, when a doctor says surgical menopause, what they are really often meaning is that woman's ovaries have been surgically removed, both of them, from her body.
Okay, because people that I've spoken to recently have kept their ovaries and had their womb removed and gone into surgical menopause or gone into menopause. I don't know if you would call it surgical menopause because they didn't go fit into that category of having their ovaries removed, but they still experience the symptoms of menopause.
Yes, and there is lots of research to sort of to support that you are at an increased risk of menopause coming along sooner perhaps than nature would have brought it to you. And what that means really is even when a woman's just going for hysterectomy, so she's just having a womb taken out, that discussion before that surgery should probably talk to her about the possibility of menopause and what it looks like and what treatments are available if she needed or wanted some. So, because a lot of these women, it's not discussed, certainly not discussed before a hysterectomy that much because it isn't your classic surgical menopause, but it's like this, like I say, that no man's land, that grey zone. So at the very least, we should probably be warning women of what menopause looks like in case it comes along sooner than we would automatically think.
Yeah, no, I agree. I so much of what you've said, I've actually just started, the questions are starting to churn in my head. For example, why would a woman have her ovaries removed? Like, what warrants that? I have no idea. Help
You've
me
got to
out.
have you've got to have a good reason to take a woman's ovaries
You'd
away.
think,
You know?
right?
You'd
Yeah, it's
and
major. Yeah,
it's a big thing to do. It's not like having your appendix out,
yeah,
you know, or your gallbladder out. I mean, they're pretty major as well. But taking a woman's ovaries out is only done when we really think it is absolutely necessary, or it should only be done when we really think it's absolutely necessary. So what are those things? Well, cancer is the obvious one.
yeah,
You know? So
yeah,
cancer is a big reason if we know there's cancer there or we are worried there's cancer there, because some of the scans we do, you know, like an MRI or a CT, if we see something that looks a bit funny on the ovaries, we can't always be sure exactly what it is.
yeah,
And sometimes the only way to be sure is to take the ovaries out, because we are worried it's cancer. And there are lots of times when it is cancer, you know, so cancer is a big reason to do it. But like I say, even just the threat of cancer in a way,
yeah,
because sometimes we take them out and we look at them and it wasn't a cancer, it was a endometrioma is a common thing that can imitate a cancer on the ovaries. So that's like a mass that endometriosis can cause. So cancer is a reason, or the fear of cancer, of something being cancer, or someone who's got a genetic
yeah,
mutation that makes them at real high risk of getting ovarian cancer one day. So BRCA gene carriers, and they're at risk of breast cancer as well because of that. But if you take the ovaries out, it's been shown you really reduce their risk actually of breast cancer.
Yeah.
as well as ovarian cancer. And then there's other genetic mutations that sometimes we advise women. We say, look, for your own sort of health going forward, actually losing your ovaries is probably a good idea, which, you know, is still a huge thing to do. So cancer, threat of cancer, severe endometriosis just on its own can create so much scarring and problems and inflammation in a woman's body that if those structures are left there, they are going to give us so much more pain. And often removing them is a way to get rid of all that horrible pain that that woman is in. So there's some of the sort of most common reasons. And then you can have cysts on the ovary that can't be removed without removing the whole ovary. Torsion is when ovaries can twist on their blood supply, and then they need to be removed because the blood's not getting to them.
Yeah.
So there's big reasons to do it, and there should be big reasons. And these days we do not do as many oophorectomies, as it's called. That's the posh word for removing an ovary. We don't do as many as we used to because we now realize those little glands are very important to a woman's health, mentally and physically. So we need to be really sure there's a good reason to take them out of her body.
Is that if your body is sensitive to estrogen, then and you have that gene for cancer, that's the connection between certain types of cancer for women. Is that correct?
So yes, it can be those sort of hormone sensitive cancers that actually the woman's own ovaries, which are kind of producing estrogen as they should, can actually then make it more at risk for her to go on to get that estrogen or hormone sensitive cancer.
Okay. Yeah.
So yeah, it's kind of, they are genetically at risk of those sorts of cancers, and by taking their own, something that was natural in them away, which sounds so alien, it does improve their chances of never getting those horrible cancers actually happening in their body.
Okay, good to know. That will probably help someone who's listening, I think. Now, on to the difference between surgical menopause and natural menopause. And I can put my hand up and say, I'm going through natural menopause. And obviously, multiple episodes before this one, I've spoken very freely of my multiple symptoms of I guess, a natural menopause, meaning that at this stage of life, my symptoms started to show up about 47. They accelerated to 49, and then I was like, what the actual is this about? And then I realized it was perimenopause after much deep diving. And so I know that I'm going through a natural menopause. What's the difference between, say, someone like me and someone who's had a hysterectomy, oophorectomy? Is that correct? The ovary one? Yeah, like tell me about that. Like, what's the experience? And yeah, it sounds crazy.
This is when that distinction between a true surgical one and a, you know, we haven't got a word for it, have we? Partial surgical menopause. I don't know, you know, there is no word for it, but it should have a word, you know, the people who've had hysterectomies or one ovary removed or damaged, or, but if we just talk about the pure surgical one for a second, where both ovaries are gone, you know, in a moment, a big difference there is obviously in a natural menopause, you have perimenopause. You have a transition, you have a time where you go from having normally producing hormones to it all going a bit haywire, you know, and eventually it goes and it declines. Whereas surgical is, you know, just overnight, it's gone. There is no perimenopause. So that's a huge sudden shock to the body. So that's a major difference. And that's obviously more pronounced when it's the true full surgical menopause. So that's a big difference.
Yeah.
The symptoms, you know, tend to kind of be the same, as in they're all the same possible symptoms, of which there's, you know, way too many. I call them unwanted gifts of menopause. You know, there's heaps of them that you just don't want. So a surgical menopause person can have any or all of the same symptoms, but they do tend to be more severe because it is such a sudden loss of the hormones. So they tend to have more severe symptoms, and obviously they come on really quickly. There isn't that gradual decline. Whereas in a partial surgical, I suppose you could call it hysterectomy or one ovary, you will tend to probably get a bit more of a perimenopause, a bit of a stuttering and fluctuating before it's all, really low. The other big difference is because in a full surgical, when your ovaries are just gone, the big hormone there that's also gone very fast is testosterone.
Testosterone, yeah. I was
You
just
know,
thinking that, yeah.
yeah, so their testosterone drops by 50%, just
Yeah.
boom, done. Which again is really sudden and a shock to the female body, because testosterone is important for girls as much as it is for boys, really. It's not a gender specific hormone. It is one that floats around in both genders and does lots of important things. So that sudden loss of testosterone is why we think is the reason behind what can be really severe libido problems in surgical menopause, like even more so than in a natural one. And it can be bad enough in a natural one. And testosterone matters in a natural one as well, but probably even more so when you're talking about surgical menopause.
Yeah.
So the symptoms, although they can be the same, they tend to be more severe. And there are some symptoms that are often more pronounced, and that includes things like sexual dysfunction and libido symptoms, and which can be really hard to talk about and get your head around, especially if you're younger when you go through the surgical menopause. Not that it's good at any age, to lose your libido, but certainly I think most of us agree when you're in your prime, that's awful, that side of things. So that kind of lack of a gradual moment, that sudden severe loss of hormones, is are the main sort of differences between a a natural one and an unnatural one.
Yeah, thank you, Linda. You've really explained that so beautifully. Now I feel like, okay, I fully understand what this is about and the implications. What are the risks for surgical menopause?
Yes, people are getting their heads around these days that actually, in some ways, even a natural menopause is not very good for our health, but it's natural, it is what nature plans for us. But lots of diseases go up in risk after a woman goes through menopause.
Yeah.
I mean, I remember at med school the graph of, and feeling quite sort of cocky about it, that women have less heart attacks than men. Heart disease is kind of men get more on the graph, they get more, and then you get to the menopause age and men and women meet, and you just go, oh, we've lost our little advantage.
Superpower. Yeah.
Superpower's gone. We
Yeah.
can't be smug about it
Yeah.
anymore. So we know that estrogen is protective for hearts, and when women naturally lose that in menopause, that protection's gone. And if you sort of artificially take those hormones away from a woman's body when she wasn't really naturally going to lose them, we think those health risks are even more significant. So that is things like heart disease, osteoporosis. Our bones need estrogen. All through our life, really. So the earlier you lose the estrogen, the worse it is for bone health. And our brains need it. So there's research that there's increased risks of dementia for surgical menopause, and depression, so mental health issues, even Parkinson's. There's some evidence that there's an increased risk of that. And what we also think with the research is if we don't replace the hormones properly, there is a worry that actually there is an effect on a woman's life expectancy without her ovaries, without her hormones. So a lot of the debates in the literature, when you read it, about should we be taking ovaries out so much, when should we do it and when should we not? The argument against it, the argument says leave the ovaries where they are, says actually you may be reducing a risk of one disease like ovarian cancer, but you're increasing her risk of other diseases. So that balance is really hard sometimes to figure out what is the biggest risk for that woman in her particular situation.
Yeah. Wow, it's a lot. Okay, so the woman that I have spoken to in the previous episodes about their experience with a hysterectomy.
Mm.
Both of them had hysterectomy, not removal of ovaries. There was a common theme that I listened to, and it was that they were not well informed of what to expect. So my question is, what should we be telling women before they have a hysterectomy or the removal of their womb? So let's break it into two parts. The hysterectomy part first, removal of the womb. What do women need to know?
Well, as well as all the stuff that we're normally quite good at telling ladies, hopefully, the sort of the standard consent form for a hysterectomy, which I don't actually know because I'm not a surgeon.
Yeah.
But what are the risks of any operation? You're having a general anaesthetic and infection and bleeding and all that stuff. But I think because in the medical field, we think about ovary removal as being the menopausal causing one, we don't think enough about how these other operations can increase the chances of menopause. There's not enough talk before a hysterectomy, probably, about, well, what if this might make your menopause come sooner? And we don't know how to predict who it does that for and who it doesn't. But what we should be saying is it may bring it on sooner than nature planned. We've no way of reversing it, putting your womb back in and then seeing where you would have got to naturally. So it's very hard to really pinpoint. And unlike with a full surgical menopause, often the symptoms are not as immediate after hysterectomy, the menopausal symptoms. But then for some women, they seem to be.
Yeah.
So I think there's so much variation because we're all different.
Yeah.
And one woman's story will never be exactly the same as another. So we have to be open to all these possibilities to say, look, for some women, it can lead to an earlier menopause. And here's what menopause looks like. You might just feel tired. You might just be aching. You might not be able to sleep. You might not have a single hot flush. There could be all these vague symptoms. You might just be feeling very low in mood or very anxious. So we need to help these women recognize what perimenopause and menopause look like, and also let them know what options for treatment are there. So if they start to feel it, they know what
They
to do
know.
about it.
Yeah.
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 And they're prepared in case it comes, and they're going into that up with their eyes wide open for hopefully all the possibilities. And then they won't feel blindsided if it comes along, out of the blue.
Yeah, because it feels to me that women, I think, possibly are quite daunted by the idea of surgery. Just that
Yeah.
part first, right? So it's just that part first. And that having a blanket conversation, whether you're having a hysterectomy or oophorectomy, just saying, okay, this is what menopause looks like. This is what perimenopause looks like. These things can happen if you're having a hysterectomy, womb removal. This could possibly happen for you, and it might take 0 days, it might take 30 days, but look out for it because we can help you with that. This is what I'm hearing you say. And then if it's an oophorectomy, it's like you will go into menopause. This is what will happen, and this is what we're going to do about it. Doesn't that just make sense?
Yes, it's so important, isn't it, to know potentially what is going to, be coming up next for you. So you're prepared for it. You're right, though. The surgery itself often takes, all the attention. And the cancer often takes all the attention, because don't forget,
Yes.
often a lot of these women are also trying to get their head around having cancer and what that means, and then maybe having chemo or what, all kinds of things. So there are so many difficult, hard things coming at that woman that often menopause gets sort of, even in a surgical oophorectomy, it gets pushed to the bottom of the list of things we need to help this woman get her head around and support her with. And sometimes even from the woman's point of view, she hears the word cancer, she hears the word menopause. Which one is more frightening? Which one gets your attention at that moment? It is the cancer. Menopause is not thought of as an emergency, even though actually in some ways and in some cases it kind of can be, especially from a mental health point of view. But in that moment before the surgery, with all the information the woman is having to digest and process, yes, it's almost difficult to throw something else in there at her, I'm sure, to say, oh, and by the way, let's have a good chat about how awful menopause might be, but we sort of have to, it's got to be all good, bad, and the ugly, to get all the information, for her. But you can't give it all to a person in one
Yeah.
go either. So this, pre-surgery counselling, it's a 1, 2, 3 session thing.
Yeah.
And in an ideal world, in surgical menopause, you would have a menopause specialist as part of the team. So you'd have your oncologist, you'd have your surgeon, you'd have a nurse, a wonderful cancer nurse, and then you, in an ideal world, would have a menopause specialist to say, right, let's talk about this part. Even though it won't feel that relevant always until it hits them. And as with a natural menopause, you don't really appreciate it often till it starts hitting you. In our 20s, we were all, menopause, what's that?
Yeah, exactly.
But we should have known about it, and we have to try and make it interesting to 20-year-olds somehow, because they need to be prepared for what their bodies are going to go through, or what the woman they love is going to go through one day.
Yeah, well, it's pretty damn interesting when you're a mother to a 20-year-old and there's pots are flying and there's rage and there's a breakdown in the kitchen.
That's you doing that, isn't it?
Yeah,
You're
it's me.
throwing the pots.
100%. And next minute you're talking about divorce, and then it sort of makes them think, this is really interesting, this stage of life.
It's good. It's a real demonstration, isn't it? Like, this is what might happen. And Nate's a funny old beast, isn't she? She really is. A bit mean to women, I think.
Yeah.
But yeah, you want to give them information, definitely, but it's got to be in the right way. Otherwise, it's just more, it's overwhelming and it's frightening, all the stuff they're dealing with. So to do it in the right way is important as well.
Yeah, that's so good to hear that, Linda. So I know that we've spoken on some pretty intense sort of medical aspects of surgery, and they can sound quite overwhelming, a little bit scary. This is just an off-the-cuff question right now, but have you seen a really positive experience that someone has gone through where they've had that level of support? Is it just like a one-off where someone's come to you and said, they were fully armed with all the knowledge, they knew that this was going to happen, now they're ready to look at the alternatives or the support that they think that they need, and they already know what that could be? Have you met anybody like that? Just putting it out there.
I think they come to me because they're not getting the info and support, though. So I'm probably not, I'm sure, and I hope there are more positive stories out there. I do think, though, surgical menopause as a whole is probably handled not as well as we could do. So in an ideal world, you would have more people who are saying, actually, no, I knew what was coming, I was ready for it, I knew about HRT, I knew about testosterone, I knew about vaginal estrogen, I knew about this, that, and the other. And I really felt empowered and ready, tooled up, to do whatever I needed to feel better. I probably hear more of the sad stories. I'm probably more skewed the other way, because they are looking for someone who can really spend some time with them. And time is often the main thing, really.
Yeah.
Consults, generally speaking, in the public system are pretty short, sharp, and not very sweet sometimes. It's hard. It's hard working in the public system on both sides of the desk. So what I see is probably more skewed towards maybe more negative stories from it. But I hate to sound pessimistic, but I think there is a lot of negative stories.
Yeah, there is.
For menopause.
Yeah.
But that's not to say it can't be turned around, but it means we should be motivated to do that.
Yeah.
Because it could and should be probably a lot better.
Yeah, I mean, what I'm hoping for is that people can now come to this podcast episode with us and know exactly what's ahead of them if they are faced with this option of hysterectomy or full, partial, whatever the options are. They can tune in, and now they know, and that makes a difference. because, you know, actually having credible resources that you can tap into, the education is empowering, right? So we're starting something, Linda.
We're starting
Yeah,
something. We
we got
are.
to do that. All right, getting on to HRT, because you've mentioned it a few times and I want to really dive deep into this.
Mm.
So do all women who go through surgical menopause need to take HRT?
So this is probably another difference between, you know, a natural menopause versus a surgical menopause. And what I didn't say at the beginning in the definition, and I should have, is, you know, surgical menopause is when we remove the ovaries before the woman's gone through a natural menopause. You know,
Okay, yeah, okay,
goes
good.
without
That's,
saying,
yeah,
you know,
yeah.
we're not going to cause a menopause if it's already happened, sort of thing.
Mm,
Although, you know, that postmenopausal ovary even is chugging out, so it's not completely stopped, especially testosterone, we think maybe goes on a bit longer. So actually, there is still some impact of removing postmenopausal ovaries, probably. But the real dramatic impact is in that premenopausal, as in they were not about to go through menopause naturally, as far as anyone could tell,
yeah,
and it's gone. But yeah, so when we talk about hormone replacement therapy, HRT, which we're supposed to call menopausal replacement therapy now, isn't it? Oh no, menopausal hormone,
hormone therapy, yeah,
MHT, but
yeah,
everybody still calls it HRT, and
yeah.
so do I.
And we're
Um,
not precious because it's just easier. It rolls off your
yeah,
tongue. People know what you're talking about. When you start going MHT, which is kind of what you should say, then people are like, what?
yeah, I think
Yeah,
it's hard to change a term when it's so entrenched in people's brains, you know,
yeah,
even if it's possibly not as fully accurate as it could be.
yeah,
But anyway, so, you know, yeah, HRT obviously stands for hormone replacement therapy. You are replacing hormones. Now, if you're talking about surgical menopause, you literally are replacing those hormones because that body wasn't ready to lose them yet, and that body was using them, you know, a lot. We call them sex hormones, don't we? We call them reproductive hormones, the
yeah,
thing the ovary makes. And what a silly name, really, because it does not encapsulate what they do at all, because they are about way more than sex and having babies. You know, there's not a cell in our body that doesn't respond to them, and our brains. So when you think of them as that sort of hormone that is giving instructions to everything, you know, losing them is a big deal. So unlike in a natural menopause, where I don't call a natural menopause a hormone deficiency, some doctors and menopause specialists do use that term for natural menopause. I don't like that term. I think it does make it sound like a disease.
yeah. I
There's
agree.
there's
Yeah,
lots of women who don't feel deficient and don't have problems with their menopause. Some people argue, oh, but you know, their health risks are going up because the hormones are gone. But I don't think we should, personally, I don't think we should call it hormone deficiency. But surgical menopause, I think we can call a hormone deficiency because we've literally removed some endocrine glands, some hormonal glands from that woman's body before she'd finished with them. Just like if we took a thyroid out, we'd give a thyroxine. And in, you know, if your
yeah,
pancreas conks out, we give you insulin. So the difference there is HRT becomes even more important for that woman to know about, be told about, and also in the vast majority of cases, reassured about, you know, in terms of safety. Similar to in a natural menopause, you know, we have all been frightened away from mainly estrogen. When we say HRT, it's mainly the estrogen that everyone has sort of just stuck with breast cancer.
yeah.
And
I was
that,
actually about to say that as well, but yeah,
yeah, you
still a
know,
little bit hung up.
it's the, you know, and it will be there. And the difference though between the surgical menopause and the natural menopause is the research we've got on HRT for people who've gone through surgical menopause. It doesn't have that small non-significant breast cancer risk, because it was not statistically significant, the breast cancer risk that was
Okay,
found with HRT. It was very small. It
yeah,
is there, we can't say there's no risk at all, but we put it in perspective and we realize it's a lot smaller than we were all led to believe. And the benefits of HRT outweigh it. But when it's surgical menopause, we really can say to that woman, because you're at a younger age, your body really does need these hormones. And we are not concerned about breast cancer. So if any, it's actually going to reduce risks of things. And the research says that there isn't any research that says there's any small increased risk of breast cancer if that woman is at a young age when her hormones are gone. So from a safety point of view, HRT is even safer. Not to say it's dangerous in a natural one, but it's kind of even safer with surgical menopause. And it's even more important because it will help to reduce and prevent some of those changes in that woman's body in terms of her heart and her bones and her brain that can make her, unwell or potentially shorten her lifespan. So it becomes even more important. That study 20 years ago, the WHI, the Women's Health Initiative, that announced to the world this increased breast cancer risk. They were looking at older women.
Yeah, over 70, postmenopausal.
Most of them weren't even having any symptoms anymore.
Yeah.
The funny thing, one of the questions in that study, they actually tried to assess if HRT worked for symptoms. So they said to the women, has this helped your flushes and your this? And the woman, most of them said no, because I haven't got any.
Yeah.
But they took that answer as saying, oh, it's not effective. So that they actually concluded also that it wasn't even effective against symptoms. And it's like, well, it's not going to treat something that people haven't got anymore.
Yeah, exactly.
So that was looking at older women, and it should never have been extrapolated to be relevant to younger women going through surgical menopause, because that's totally different physiological thing. That's not the same as a older woman who's gone through a natural menopause, is way past that age. You can't compare those bodies and their response to hormones. So, but that study put everybody off HRT, including people who were going through an early menopause or having a surgical menopause, because everybody just was worried about breast cancer since that study. So it really did harm surgical menopause patients.
Yeah.
It harmed you could say it harmed a lot of women's quality of life and possibly longevity of life. But certainly for surgical menopause, it really did harm their life expectancy and their quality of life.
Yeah, that's so crazy. So isn't it like the risk of breast cancer on HRT is the same as the risk of breast cancer when you're not on HRT? Something like that.
So the way I explain it is this: there's that study 20 years ago. If we look at what they found, so they looked at women on no HRT. They looked at women on combined HRT, which means that's women with wombs who have to take estrogen and progesterone. And they also looked at women who'd had a hysterectomy and were just on estrogen HRT. Because if you've not got a womb, you don't have to take progesterone. If you want to take estrogen, you can safely take estrogen alone. And some people say they can be compared to a woman with a Mirena taking estrogen. So there's some data to say having a Mirena potentially is almost the same risk then as estrogen only HRT. So when they looked at those three groups and they looked at the breast cancer rates in them all, the women on no HRT still got some breast cancer. There was breast cancer in that group because not every woman who gets breast cancer ever took HRT. Most women have never taken HRT who go on to get breast cancer. Then the women in the combined group had slightly more cases of breast cancer, but it was so small that it wasn't statistically significant. So it was there, but it was an extra 8 cases per 10,000 women, which, as you say, is lower than the risk of getting breast cancer from drinking 2 or more alcoholic drinks a day. And it's lower than the risk of getting it from being overweight. So that was that group. And then when they looked at the people on just estrogen, they actually had less breast cancer than the people on no estrogen. Again, it wasn't statistically significant, so they didn't tell us. But
then report it.
Why did they tell us just the bad news instead of the good news then, if they were going to tell us every non-statistically significant result? So there was no significant difference in breast cancer risk between the 3 groups. But if you want to look really closely, you say, actually, there was a non-significant protective effect from estrogen, and there was a non-significant increase in risk if you put progesterone in with the estrogen. But for some reason, estrogen came out of that study as the bad guy, and progesterone came out of it as the good guy, which I've always found a bit weird.
Yeah.
But that's what happened 20 years ago. We've come a long way now since then and decided there are more benefits to be gained from HRT than risks, especially if you're talking about women who are younger and who have been plunged into a surgical menopause.
Okay, I want to dial back to the cases or the stage of life of women having a hysterectomy. So we covered the challenges with being premenopausal when you are not experiencing menopause symptoms or perimenopause and you have to have a hysterectomy or go into surgical menopause. But what about postmenopausal women? So just thinking about this, is there quite high cases of postmenopausal women having hysterectomies? I don't know.
Not so much. I mean,
Okay,
but I think it's done a little bit if we're worried about cancer. That will
right.
be, because they can go on to get womb cancer or ovarian cancer. The rates of those cancers do go up as we get older. So that would be why we'd do a hysterectomy and remove the womb or remove the ovaries after menopause has already happened. Whether that then, because the hormones have already gone and the woman's body may have adapted, you don't, I think, see the same sort of consequences of menopausal type consequences from that. But yes, sometimes we do take wombs out of women's bodies even after they've been through menopause, mainly because of cancer.
Right.
The most common reason we do hysterectomies at any age is often because of very heavy, terrible periods or very terrible endometriosis. But
Yeah.
post-menopause, obviously she won't be bleeding anymore, so we wouldn't have to do it for that reason. And the endometriosis often does calm down after menopause anyway, usually. So it's not flaring up so much that we end up removing things to just stop all the pain that the woman's in.
Okay, that's good. That really answers that. Thank you. Okay, I've got another question here from me, and then I'm actually going to take a question from the sexy aging Facebook community because they're very vocal about they have things they need to know. But here we go first. How do you know what dose of HRT to give a woman after surgical menopause, and when should she start taking it?
Yeah. So you could ask those questions to a natural menopause person as well, about natural menopause. How do you know what to give in a natural menopause? And when should she start it?
Mm,
You know? So those questions are actually relevant for any type of menopause, really. When it comes to surgical menopause, obviously you've got like a date, you've got an operation date, So in terms of the when, I'm not a surgeon, so this would probably be a good question for a surgeon. I'll find one for you.
let's do it. Yeah.
I've got one in mind.
Okay.
But I know of, some surgeons saying, I put a patch on the night before I do the op, to basically get that replacement going, or, the day after, or the day of the op after it's happened. Because I think there was some worry between clotting risk. After an operation, someone is at risk of clots because your body's been traumatized, so you go into clot mode. So that's why people can get clots after a surgery. And oral estrogen is associated with a small increased risk of clots. But now, as we have patches of estrogen that have removed that clot risk, I think surgeons are less concerned about an increased clot risk by starting the HRT really soon around the time of the surgery. So because the patches don't have the clot risk, we can be sort of more relaxed about starting HRT closer around a woman's surgery, is what I believe anyway. But there may still be that nervousness possibly in the surgical world and beyond to say, well, should we let the body get over that initial clot reaction of the surgery and then bring in something a bit after that time has passed. But yeah, I've heard, patches going on the night before by the surgeon and even, straight away after. In terms of dose, nobody really knows, is the honest answer. Nobody really knows what is the perfect dose for that woman at that age, because of that operation. Because it's the same with natural menopause. You talk to your friends or your mum or everyone's on something different. It's, with HRT a lot of the time. And you can get a bit confused and think, well, why are you on that dose? And why am I taking my progesterone every day and she's taking it not every day? And, there's all this tweaking and differences. generally speaking, we think, and well, we're pretty sure they need higher doses
Yeah.
than your standard kind of maybe natural menopause dose, because their body was in its prime with the hormones. So it was used to high levels, it was needing high levels. So you should try and match that. The other problem is people vary in how well they absorb through patches. So, the same dose patch on two women can be being absorbed very differently. And one absorbs it brilliant, it's all getting into the blood and she feels great. And the other one just, the skin won't absorb it for various reasons. So you go with a higher dose patch, but you're actually getting about the same levels
Mm.
probably, because she just doesn't absorb it as well. But there isn't this nice, neat number that we've all figured out that is going to be a perfect recipe for every woman. And it's the same with a natural menopause. There's no perfect hormone level in the blood to aim for. It is the woman's body tells you if it's got enough, really. So you give something and then you step back and the body will let you know. And sometimes it can take a few weeks, just like in natural menopause with HRT or a dose change. It can take a few weeks to kind of settle in. But generally speaking, we think they need higher doses, and probably as close to the surgery, especially if it's surgical removal of ovaries, that full surgical menopause, to just get the hormones back in rather than waiting potentially for symptoms to develop. If they've just had a hysterectomy, I'd probably be more inclined to say, let's wait and see what your body's going to tell us, because not everybody go on to get menopausal symptoms, because maybe the blood supply to the ovaries was not impacted at all. So we don't ever want to give medications for not a good reason, if you like. And as wonderful as HRT is, and as much as it imitates nature, it is still a medication, you know. So we still want to be somewhat careful with it, and use it
Mm.
when necessary, and not use it if it's not necessary. Um,
Yeah. Well, you've just
yeah,
answered the question from the Facebook community, which was with a partial hysterectomy or removal of the womb, when is the best time to start HRT? And because it feels like surgical menopause, it's kind of almost a no-brainer, right? You've been thrown into menopause. Whereas a partial hysterectomy, it's like, well, yeah, let's just wait and see. So yeah, that answers the question. Thank you.
but we shouldn't wait till the woman's, on the floor, or
Decimated, yeah. Yeah.
yeah, as long as she's got that info to look out for the stuff, then she is going to get onto it if she wants to. It's not compulsory. Um, if she wants to, it's not like the ovaries are gone, so we're not really fully replacing. So if she
Yeah.
wants to, then she can listen to her body and get it if she needs it, sort of thing. Sooner rather than later, though. There's no
Yeah.
waiting.
How long should a woman take HRT after surgical menopause? This is a good question.
Yeah, so a lot of the things that you read in the guidelines about surgical menopause say, you know, those who go through surgical menopause before the natural age should be offered HRT until the natural age of menopause, or it says until at least the natural age of menopause. And it's that at least bit that matters. And I think most guidelines now have those two words in it, but there might be some that forget to put those words in, and then it sounds like, right, you're 50 now, we're cutting you off,
Yeah.
which is not true and shouldn't be true. So there shouldn't be this expiry date there. Just the same as with a natural menopause, we now say there shouldn't be an automatic expiry date, as in, oh, you've been on it 10 years, now you can't have any more. It's too risky. We don't think it is. We think women can and should be allowed to continue on it if they're still feeling benefits, or if they want the health benefits that we think is there. So, and same with the surgical menopause, it should be there in their body until at least the time nature was going to take it away from her anyway. But actually, that doesn't mean she has to stop it then. Just like in a natural menopause, lots of women continue for longer than that. And often the symptoms of menopause can be worse, can't they? After the magic cutoff of 50, 51,
Yeah.
it's
I'm
kind of,
like, why would you do
yeah,
that?
sometimes it's just ramping up then, isn't it?
Yeah.
You're just like, I
Yeah.
need it more now than I did when I was 45.
Yeah.
So, yeah, there isn't a time limit, but the way guidelines are written, it sometimes sounds like that. And maybe in some doctors' heads, it comes across as that sort of a rule. And I know a lot of surgical menopause patients who've read guidelines and sort of panicked almost. They're like, oh my God, so that I'm not going to get this as soon as by the time I'm 50, it's just stopped, supply just gone. No, that's not how those guidelines should be written. If they, some are written like that, because it doesn't just stop.
Okay, I want to segue into testosterone. So I know under HRT we are generalizing that we can access estrogen and progesterone, and that's quite common. It's still challenging for a woman to access testosterone for a normal menopause. So what about with surgical menopause? Are you offered testosterone, or is that completely off the table as well?
I think it's still a bit out there when it shouldn't be. Yes, it's still a little bit of a wacky sounding thing in some sort of areas. Testosterone. What are you going on about? That's for men.
Yeah.
Um, so but it's getting better. I mean, is it any better or easier to get testosterone if you've had surgical menopause than if you've had natural menopause? I think at the moment, I probably have to say I don't think it is any easier or better. I think there's a blind spot in both those areas. And the fact there's a blind spot for it in surgical menopause is even worse, really, because they have lost that hormone massively in a very sudden way. Um, so it's not as kind of in the front of healthcare professionals' minds, if you like, that this is an important thing that they are probably going to need. And I need to find out how to prescribe it, and I need to know how to twiddle with it and what blood tests I need and what. So there's definitely a need for more awareness on both sides about testosterone. From the patient should know about it and be given information on it, and so should the person who's hopefully going to prescribe it. Feel more comfortable with it, that it's not this wacky, weird thing that we're talking about, giving women testosterone.
Yeah.
It's the hormone that's important for us as well. So that's another crusade, really, for us all to get onto, that, to normalize that hormone in women, especially in the surgical menopause area, but in the general menopause one as well, really.
Yeah, yeah. So we've spoken of HRT as a really good option to support women through surgical menopause, and of course we know it also is a fantastic option for normal menopause. What about the contraceptive pill? What do we know about that to support symptoms post surgery as well?
So that is another option that should be on the table for women who are going through surgical menopause or any sort of early premature menopause as well, because it can help replace and sort of mimic the hormones that you're not making anymore. And for some women, especially if they're a bit younger, it feels less stigmatizing to be on the pill than be on HRT. The image of it it feels more comfortable with them to be taking the pill like most of their peers might be taking, rather than saying, oh, I'm taking HRT, because it's got that kind of menopause connotation. But we should try and get away from that, because there are some things about HRT that are actually better than the pill. One of them I mentioned, which is if you eat if you eat estrogen, you have the small increased clot risk that way. And the contraceptive pill is obviously just oral. So you've got that problem with it, that's the small clot risk there. The other problem is it's fixed doses. You can't tweak it, tailor it,
Mm.
sort of change it. It's just a set dose of estrogen, set dose of progesterone. That's it. And they're not body identical hormones either that's in there. So they're not quite mimicking nature perfectly. Whereas the HRT, you can get body identical estrogen and body identical progesterone. So it mimics nature and it fits on all the receptors nice and perfect then.
Yeah, I actually just want to stop and say I absolutely love how you've just explained that part there, because I've mentioned to quite a few women lately that the HRT is more natural to the body than the contraceptive pill. And the amount of women that go, what?
Yeah.
Like, as soon as I say that, they're like, oh, so why wasn't I thinking that I should take HRT? It almost changes the game for them. It makes them think that it's probably time to explore it. Whether they take it or not, it's completely up to them. We know it's not a silver bullet, but it works really well for lots of women. But it's that concept that they've been taking the contraceptive pill for 25, 30 years, never thought that HRT was closer to the body's physiological hormonal makeup than the contraceptive they've been taking for decades. Interesting, isn't it?
Yeah, it
Mm.
is. HRT needs a makeover. It needs an image. It needs a PR campaign. Because it's just
Totally.
it had a terrible one, didn't it? That one
Yeah.
20 years ago was awful.
Yeah.
And all the positive aspects of it just got buried, and it just got locked away in the breast cancer box, and that's where it stayed. But yeah, and the other thing, the pill is potent. They're more potent, the hormones as well, because it has to be strong enough to stop pregnancy and to stop ovulation. So they're pretty potent. So actually the hormone levels in HRT are not as potent. And there's also other things that are better about HRT. So HRT can help with migraines, whereas the pill can make them worse. HRT actually can sometimes help with blood pressure, whereas the pill can make it worse. And from a bone health point of view, we actually think, especially for surgical menopause, that we think the benefits in terms of bone are better with HRT as your replacement rather than the pill, probably because it mimics the natural estradiol hormone so well. Again, it fits on all the receptors perfectly. So we think from a bone health point of view, we probably should be PR campaigning for HRT for women who've been through surgical menopause rather than the pill, for all those reasons. Yeah.
Yeah. Dr. Linda, my friend, I've been 100% schooled in surgical menopause. I have no other questions. I feel like, okay, I know this topic now, and I want to thank you so much. I'm so grateful. Now, I just want to also highlight that you are doing some absolutely phenomenal work in Australasia, in our region, to elevate the conversation around education for menopause, understanding what New Zealand women are actually experiencing, what they're telling us. You've already got over 4,000 responses to a survey, which is like phenomenal. So thank you so much for the amazing work that you're doing for the women of Aotearoa, and Australia, I think, is pretty excited as well about some of the stuff that you're doing. Is there anything, what hopes do you have for the very near future with your purpose today?
Well, it is about getting the good information out there, isn't it? And in a way that people are going to listen to it. And when I say people, I mean obviously women, but I mean men as well. And I mean young people, like we mentioned earlier. How do you get a 20-year-old interested in menopause? It's just, they think it's so boring, don't they? But it's not. It's so big and fascinating and inevitable, that, yeah, if I can help kind of mainstream it and make it something that people care about as well, I suppose, because I feel like it's been unloved, really. So I'm just one of many people, and you're doing very good things as well out there, Trace. So I need to say that. We're shining a light on it, and this place has been a bit dark, and people have struggled on with it for a long time. And we want to shine some light on it, and we don't want to be too negative, and there's lots of positives, but we do need to be honest,
Yeah.
and about all aspects, good and bad, and put it into languages, or a type of language, and a style that gets it out of the boring box, because it's been stuck in the boring box, I think, too long.
Yeah, I agree. I think it's a fascinating topic, especially when you're experiencing it. And if you,
I mean,
you
we're
know,
highly motivated.
yeah, and then you just kind of go, oh, I really want for women that are coming through or approaching the stage of life to not have the fear factor, to not have the lack of knowledge, and to really tackle it with the tools that are available, to not be afraid to ask or to go to their GP and go, yep, here we go, I'm in perimenopause, hook me up, doc. Like to not have that problem, and it's not taboo, and it's not something to be afraid of, or like or linked to the whole ageism conversation. It just is a natural stage of life, and it's been overlooked, and it needs a PR agent, exactly what you said. Yeah. We're going to make menopause sexy.
Well, it's sexy aging. There we go. You know, you've
100%.
already started that PR campaign, and I'm
Yeah.
100% behind you.
Yeah, thank you. Well, look at you. You fit the mold. Happy to share this platform with you, Dr. Linda. So thank you so much for your time today. It was incredibly enlightening. I'm so excited to put this episode out there. And yeah, let's catch up soon.
We will. Really good to talk to you as always.